appreciate the chance to participate in this meeting. I'm sorry I couldn't be present because of a scheduling conflict, but Dr. Hankins agreed to let me record the talk ahead of time, and I hope you find this informative. The topic today is going to be the importance of durable complete remission and how to achieve it. And Dr. Hankins asked me to do this because of a video he saw on my comments on ketoconazole and leucine. It's available on YouTube. But that work was done, finished by 2010. And of course, the field has made major progress since then. So I'm going to take the concepts that we used in that work and update it. So why complete remissions? Well, I think one of the lessons of the last 50 years of cancer treatment are that complete remissions matter. Across multiple cancers, partial remissions only result in a minor, months to years, impact on survival. Complete remissions are required to get long-term disease-free survival. Complete remissions require well-designed combinations. It's uncommon in cancer treatment to get a durable complete remission with a single drug. Also, for diseases like Hodgkin's disease, acute leukemia in children, and cancer of the testes, remissions are best if they're obtained rapidly, within 3 to 6 months. Otherwise, there's time for resistance to develop. How do we induce complete remissions? The traditional approach that was common during the late 60s and early 70s when such progress was made was based on a series of simple concepts. One is that combinations have an advantage over single agents, and this falls directly out of probability. If you take 3 drugs, each with a 1 in 100 chance of failing, if you combine 2 of them, the odds of failure are 1 in 100 times 1 over 100, or 1 in 10,000. With 3 drugs, it becomes 1 over 1,000,000. So the odds of resistance becomes to the combination is much lower than the resistance to each individual agent. Another central concept in this classical era was that toxicities of the drugs should not overlap and drug interactions should be avoided. And in addition to the early success in cancer treatment, this has become standard in many infectious diseases. For example, AIDS and tuberculosis are currently treated with 4 drug combinations. In fact, this principle seems to apply in any treatment situation where resistance is likely to develop. So the question is, why has this approach failed in metastatic prostate cancer and indeed in many of the cancers of adult life? Well, the first problem in prostate cancer is that until recently, complete remissions have not been common. An example might be cabozantinib. And when that drug was early testing, there were some very dramatic responses. And this shows a slide that had considerable traction during that time. On the left side, you see 2 images, front and back, of the patient with bone metastasis. And on the right, the front and back image showing complete absence of metastasis after treatment. And of course, this is very exciting. Unfortunately, this didn't happen often enough with cabozantinib, and that has complicated its development. And indeed, this has been more the case until recently. There are new drugs and new combinations appear to improve this situation. One of my favorite examples is the PREVAIL trial. In this trial, patients who were failing RH agonists were randomized to placebo versus Xtandi. And just under 20% of the patients entered a complete remission. This is actually quite an exciting development. Complete remissions to single agents are uncommon in most cancers of adult life. In this situation, Xtandi was being used as a second line agent, And in fact, about 80% of the people in that trial had also failed Casodex. So in that situation, it was a third-line agent. And to get a 20% complete remission with a single agent in those situations is quite exciting. Now, the other development, of course, is the CHARTED trial. This trial looked at Lupron versus Lupron plus Taxotere and showed a very significant survival advantage in people with high-volume metastatic prostate cancer. This slide was sent to me by Phil Kantoff when he and I were discussing these issues. And he pointed out, if you look at the bottom, undetectable PSAs were far more common in the patients on the combination than they were with hormonal therapy alone. At 6 months, is 27.5% versus 14%, and at 12 months, 22.7% versus 11.7%. And these differences are highly significant. Because I think the depth of tumor cell kill is important. I think this slide shows why the combination was successful. So the question is, what are the major barriers to further progress? Well, one of the major problems is that prostate cancer is variable at a molecular level. This is true for other common cancers of adult life. So what is the source of this variability, and what can we do about it? Well, the first source of variability between patients are in the variability of mutational events in various patients. Now, in prostate cancer, we're late to this game. Probably the best example of this is lung adenocarcinoma. And in 2003, lung adenocarcinoma was basically one disease, and the patients were treated as a single entity. But by 2012, we knew that all lung cancers are not the same, that there are a series of mutations in various subtypes of lung cancer, and much of the advance in the treatment of this cancer has revolved around identifying drugs that target these individual mutations. So one solution is to document the mutations important in prostate cancer and target these mutations, and furthermore, to develop effective combinations based on this information. As a proof of concept, I'd like to talk about the DNA repair mutations. And the key paper in this area was published by the people from the Royal Marsden in New England Journal of Medicine in 2015, October of that year. In this trial, they had 49 patients who failed docetaxel and either abiraterone or enzalutamide. This is a group of patients, of course, we all know, don't have a very good prognosis, and we lack agents effective in that situation. And they tested the PARP inhibitor, olaparib, at a dose of 400 milligrams twice a day. Overall, 33% of the patients responded. And in an advanced group of patients like that, a 33% response rate to a single oral agent is actually quite impressive. But even more interesting, 16 of the patients in the trial had DNA repair defects, and 14 of the 16 responded, an 88% overall response rate. And that is truly a stunning result. The most common mutations in DNA repair were BRCA2, where 7 patients had this mutation and 7 responded, 100%. The acetylcholine mutated the ATM gene. There were 5 of those patients and 4 responded. So while the numbers are small, these are rather stunning results. Clinical effectiveness of 88% response rate to a well-tolerated oral drug in heavily pretreated patients is stunning. The other thing about this paper is it suggested that up to a third of patients failing docetaxel had BRCA2 or ATM mutations. That was a surprise, but there is independent confirmation of that. Again in 2015, there's an article in Cell it was an exhaustive compilation of all the mutations seen in advanced prostate cancer, and BRCA2, BRCA1, ATM mutations were seen in just under 20% of those patients, again within the ballpark of the Royal Marsden study. Independently, in collaboration with Caris Life Sciences, we presented at ASCO GU that we were able to see BRCA2 mutations in 11% and ATM mutations in 11% of patients with advanced prostate cancer. So taken together, these observations suggest that 20 or 30% of patients with advanced prostate cancer may be candidates for olaparib. But as we talked about at the beginning of this talk, single drug treatment is often of limited durability. Olaparib fits this pattern. But while response rates are high, resistance develops quite rapidly. So what can be done about this? Well, of course, in line with the thinking we talked about in the first few slides, combinations. So again, with the Caris data set, we were able to show that 80% of the patients with ATM or BRCA2 mutations were predicted to be sensitive to carboplatin. This is based on low or absent expression of the RCC1, the major enzyme involved in excising the double-stranded crosslinks that platinum's agents cause. These results are currently unpublished. So one potential approach is to combine olaparib with carboplatin in these patients. And fortunately, that combination has been developed and tested in ovarian cancer, so we actually know the dose and schedule that is tolerated. So one reasonable next approach is to test this combination in patients with BRCA2 or ATM mutations. The next problem is that there can be changes in gene expression that don't involve mutations. This goes under the term epigenetics, and these are biochemical events that alter gene expression without changing the DNA code. This can result in an increase or decrease in expression of a wide range of genes. However, the genes are normal by DNA sequencing, but just not expressed or have their expression altered. We now know that epigenetic changes play a major role in the evolution of prostate cancer, particularly gene methylation changes. Two drug classes have been developed that have an impact on epigenetic changes. There are demethylating agents, azacitidine and decitabine. These were originally tested at high doses as cytotoxic agents for leukemia, but we now know at low doses the agents become much less toxic and can reverse DNA methylation changes in cancer. As far as we're aware, that these agents haven't been tried against prostate cancer at DNA demethylating doses. Another epigenetic change important in prostate cancer involves changes in histone, the activity of histone deacetylase, which affects chromatin structure. And there are a group of agents listed below that have been developed as HDAC inhibitors. Many of these have been tested against prostate cancer, but not in a clinical setting where the concept can be adequately tested. So, how can we put all this together? We're rapidly identifying new agents for prostate cancer. We're learning the genetic landscape, the molecular landscape of the cancer, and we're developing candidate agents in increasing number and diversity. So what are the valid strategies for developing combinations? One is to combine agents within a treatment class. So if you take hormonal therapy, clinical trials are testing LH, RH agonists combined with Xtandi or Zytiga progressively earlier in the disease. Chris Logothetis will be talking later, has taken the lead in developing the combination of Xtandi and Zytiga. Xtandi, a drug that binds to the androgen receptor, and Zytiga that blocks the synthesis of testosterone within the tumor cell. Cytotoxic chemotherapy, We have seen that Taxotere is active. Again, Dr. Logothetis has taken the lead in testing Gevtana and carboplatin in patients with very aggressive prostate cancer, particularly those with anaplastic disease. Immunotherapy is an area of considerable ferment, and one strategy is to combine checkpoint inhibitors. And so clinical trials are testing agents that block CTLA4 and the PD-1 ligand. Also, Eric Small has taken the lead in combining antagonists of CTLA4 with leukine, a cytokine which is a broad stimulus of immune function. Finally, trials are going forward testing Provenge and other vaccines in combination with checkpoint inhibitors. A different approach, ultimately one that I think will be more fruitful, is to combine modalities. Mark Emberton at this session will be talking about the treatment of oligometastatic disease. This is the concept that patients may have a few deposits of active disease, and if those deposits are attacked with focal therapy such as radiation, there can be a benefit. One logical next step is to combine focal therapy of oligometastatic disease with systemic treatment. Another approach is to combine hormonal therapy with cytotoxic chemotherapy, and the Charter trial showed the Lupron and Taxotere is an effective example of that concept. Another concept is to combine hormonal therapy and immunotherapy. There's rather extensive laboratory data to suggest that hormonal therapy and immunotherapy may complement each other, may even be synergistic. So we have trials published suggesting a benefit to combining Xtandi with Provenge, and then an old study, again by Eric Small from the mid-2000s, showed that ketoconazole, a hormonal therapy agent combined with leukine, resulted in a 75% response rate in hormone-refractory prostate cancer. So I think this is one approach that's worth pursuing. Xofigo, while it's radiation, it's really intravenous administration of an isotope, and is best, I think, thought of as a systemic agent, and trials are going forward testing Xofigo in combination with various hormonal therapy agents, Xtandi, Zytiga, or in combination with immunotherapy. Xofigo and Provenge, for example, is being looked at. The final idea I could come up with is to take gene-targeted drugs and combine them with any of the above strategies. And of course, olaparib is an agent we've just talked about that I think has considerable promise. The other drug, which we haven't talked about, is Sprycel, dasatinib. And there's some very interesting laboratory and clinical data that suggest that Sprycel interferes with the progression of bone metastatic prostate cancer. And again, Dr. Logothetis has been taking a lead in looking at Sprycel and prostate cancer in combinations. So in summary, new drugs, new combinations are increasing the magnitude of tumor cell kill. Even at this early stage, we're seeing an increased proportion of patients entering complete remission. I should point out that much of this progress is a result of the fact that this cancer has become a hot topic and is attracting some of the brightest young scientists and clinicians. And as a result, there is a dramatic increase in the ideas being tested. So the next question is, how do we make these remissions durable? By durable, I mean for the patient with metastatic prostate cancer, remissions that last between 5 and 10 years. Currently, even dramatic responses fail after between months and 2 years. So we need a conceptual framework that improves the durability of these responses. And I think that one potential path to take is to look at the phenomenon of cancer dormancy. And this is nicely illustrated in this slide from a review, the citation of which is on a slide, you'll see in a few minutes. So the cancer progresses, diagnosis is made, treatment is done and the volume of cancer drops to undetectable. We call minimal residual disease. Scans are clear, markers are normal, but we presume the cancer persists, and the patient will stay in remission for months, years, or even decades. And then all of a sudden, the cancer returns. This has been well documented for breast cancer. Women who've had a mastectomy can recur 20, 30, even 40 years after a mastectomy. Even for prostate cancer, we know that after radical prostatectomy, patients can be free of disease apparently for up to 20 years and then recur. So the question is, what's going on during this interval? Why does the cancer stay silent for all this long period of time, for up to decades, before coming on? And that concept is cancer dormancy. So what is the cancer doing when it's invisible for all these years? The cancer survives but does not grow. In practice, it appears that there is either a dramatic slowing or a complete arrest of cancer growth and spread during the period of cancer dormancy. This is an area of very active research. I just checked, and PubMed lists over 1,000 papers on this subject. There's even an entry in Wikipedia that's written for lay audience that does actually a pretty good job of portraying what we know about us. There are three mechanisms, known mechanisms of maintaining cancer dormancy. One is anti-angiogenesis. The tumor does not develop a blood supply, and so it cannot grow because it is starved for oxygen and food. The second mechanism is ongoing immune attack, and the third is blockade of the various biochemical pathways that support growth and indeed spread. Now, there's really a very excellent introduction to the broad concepts in Nature Reviews Cancer, published 10 years ago. And while the paper's 10 years old, it is still an excellent introduction to the basic concepts behind cancer dormancy. And I would recommend anyone interested in the subject start there. So, thinking about prostate cancer, what would be the ideal properties of a dormancy program? Well, first, since you're talking about maintaining dormancy for decades, then the treatment has to be suitable for chronic use. It has to be low in toxicity. It would be even better if the cancer dormancy program improved general health. And because decades are involved, it has to be convenient for patient and physician. And expense, well, sadly, this has become a major issue. All too often, new cancer drugs are being priced at $10,000 a month, more or less. And even generic drugs have seen their prices skyrocket. So expense is a major issue. The first agent I'd like to talk about that I think might fit the cancer dormancy concept is metformin. And this is a drug that's been used for diabetes since the late 1950s. And it's certainly cheap enough, pennies a day. Metformin works on diabetes and other tissues by making them more responsive to insulin. Additionally, some diabetics will convert protein to sugar in the liver, and metformin reduces this. Interestingly, while this drug reduces hyperglycemia, it rarely induces hypoglycemia. It is also one of the safest, most effective weight loss medication, something that is not widely appreciated. Well, metformin not only affects diabetes and weight loss, it appears to have activity against many cancers, and in the laboratory, slows aging in general. Now, the most successful general strategy for slowing aging is calorie restriction. And not only does calorie restriction across multiple models slow aging, it also reduces cancer incidence, mortality, heart disease, and stroke. Calorie restriction works by flipping a switch, AMP kinase, which is activated when energy is restricted. What's interesting about metformin is it activates AMP kinase without calorie restriction. How is the anti-cancer activity of metformin discovered? Metformin, as I noted previously, was shown to treat diabetics by activating AMP kinase. AMP kinase was shown to activate the tumor suppressor gene LKB1 in 2003. In 2005, the incidence of cancer was shown to be low in diabetics on metformin. In 2006, this was shown not to be true of other diabetic drugs. Metformin during hormonal therapy. This is a very interesting trial published in the British Journal of Urology in 2012. And the control arm was Lupron or Zoladex with bicalutamide for 3 weeks. In the treatment arm, metformin was given once a day for 2 weeks, and then twice a day. And then the patients were put on a low glycemic diet and aerobic exercise. The difference in weight in the two populations, the people on metformin were lighter by an average of 11.8 pounds, highly significant. Body mass index was also reduced. Systolic blood pressure was improved, again, significant. In patients who had metabolic syndrome entering the trial, in the control group there was no change. In the experimental arm, there was a 57% reduction in the risk of an instance of metabolic syndrome. The other paper, I think, which is important to think about, was published by Michael Zaleski, who's in charge of prostate cancer at Memorial Sloan Kettering. And they looked at 2,901 patients. 157 were diabetic on metformin, 162 were diabetics not on metformin, and the time on treatment was 5.3 years. And the key finding is the risk of castrate-resistant prostate cancer was markedly reduced by metformin. As I mentioned, also, metformin has a favorable impact on the side effects of hormonal therapy. The specifics were actually quite stunning. If you looked at diabetics not on metformin, they had a 14.8-fold greater odds of hormone resistance than those on metformin. Even more amazing is non-diabetics, who of course are not on metformin, had nearly a 9-fold increased risk of hormone resistance than diabetics on metformin. No other drug that I know of has even remotely this impact on the development of hormone-resistant disease. This shows survival at 10 years in this study. And of course, diabetics don't do well. Not on metformin, only 55% were alive at 10 years, compared to 81.6% for diabetics on metformin. However, the diabetics on metformin even did better than non-diabetic patients, with about a 10% greater survival at 10 years. So metformin not only reversed the disadvantage that diabetics have, but improved the results over and above non-diabetics on metformin. So metformin is an interesting agent. The next topic that's worth looking at is cholesterol. This slide shows the impact it's a result of a meta-analysis of prostate cancer-specific mortality in a group of patients with advanced prostate cancer. And as you can see, this meta-analysis shows a very consistent improved survival in patients with aggressive prostate cancer who are on statins compared with those who are not. There doesn't appear to be any significant advantage for patients with non-aggressive disease. So the question is, why should statins have an influence on aggressive prostate cancer? Well, I would point out that abiraterone is approved for the treatment of prostate cancer because it blocks the conversion of cholesterol to DHEA and androstenedione, and thus testosterone and dihydrotestosterone. And this is because one of the main mechanisms of hormone resistance is prostate cancer cells take up cholesterol and make their own testosterone, intratumoral androgen synthesis. Well, of course, if you reduce cholesterol production with a statin, you'll gain some of the benefit of abiraterone. In fact, it may well be possible that better cholesterol control would make abiraterone a better agent by not allowing excess cholesterol formation to overwhelm the effectiveness of the drug. But statins have anti-cancer activity by other mechanisms. The same pathway that leads to cholesterol synthesis also leads to activation of RAS, the RAS oncogene, and other oncogenes like Rho and RAC. This was actually pointed out way back in the early 1980s, shortly after statins were discovered by Brown and Goldstein, the two folks who got the Nobel Prize for their work on cholesterol. So, what about the impact of statins on cardiovascular and overall mortality? Now, I might say that in general, the internet can be a terrible source of information, and I think that nowhere is this more evident than with statins and cardiovascular health. And certain websites would make you believe that statins are poisons with no effectiveness, and indeed nothing could be further from the truth. So again, meta-analysis. This looks at patients on statins and their overall mortality. The top figure looks at patients with known cardiovascular disease and those with elevated cholesterol but no known cardiovascular disease. So it's pooled data. The middle slide shows the overall survival of patients with known cardiovascular disease on statins. And the bottom figure shows the primary prevention situation, where the patient has no known cardiovascular disease but is on primary prevention. And consistently, there's a modest improvement in overall survival. I think this settles pretty convincingly the question of whether these drugs are seriously toxic. The benefit seems to outweigh the harm. This looks at cardiovascular mortality. And again, the top is the pooled data of patients with known cardiovascular disease and those on a primary prevention scheme. The middle is patients with known cardiovascular disease. Again, a consistent survival advantage. And the bottom looks at statins in the primary prevention situation, those with elevated lipid levels and cardiovascular risk, or taking the statins to prevent cardiovascular disease. Again, a very consistent survival advantage across all those situations. So in summary, statins appear to have a favorable impact on the natural history of aggressive prostate cancer. Statins have a favorable impact on cardiovascular and overall survival. So how do we approach this? Well, there are no randomized controlled trials randomizing advanced or aggressive prostate cancer patients to placebo versus statins. So in that context, our use of statins simply follows the national guidelines for use of statins in cardiovascular health. We do not use statins if cardiovascular risk does not indicate their use. The next drug I'd like to talk about is dutasteride, well known to anyone involved in prostate disease. This agent blocks the conversion of testosterone to dihydrotestosterone, but also increases serum testosterone. Why might this play a role in cancer dormancy? Well, dihydrotestosterone plays a central role in regulating blood flow to prostate tissue. For example, advanced BPH is often associated with prostatic hemorrhage, and dutasteride and finasteride are very useful in shutting off prostate hemorrhage. Specific data on the use of prostate cancer in a tumor dormancy situation, the best information I am aware of is the ARTS randomized controlled trial published by Fritz Schroeder in European Urology in 2013. This trial randomized patients with PSA only recurrence after prostatectomy to dutasteride versus placebo. At 2 years, there was a greater than 50% reduction in metastatic prostate cancer requiring hormonal therapy. This agent is also now generic, and that saves in cost. However, at present there is no randomized control trial showing that the impact on recurrence translates into improved prostate-specific survival or overall survival. Earlier we mentioned role of the immune system in cancer dormancy, and there's an excellent review in Cancer Research published in 2014. I can recommend it. This is a figure from that paper. On the right you have the overt active metastasis with blood supply and ready to go. On the left, it shows the panel of the dormant metastasis where the cancer cells are surrounded by members of the immune system that are suppressing growth. These are in the top circle, the immune evasion, the various things the cancer cell does to avoid control by the immune system. And in the circle below are some of the immunotherapeutic interventions that have been shown in the lab to successfully support cancer dormancy. And they include cytotoxic lymphocyte and natural killer cell activation, checkpoint blockade, and a variety of other maneuvers. So this is the theoretical and experimental basis. Of course, with prostate cancer, we're still early in the examination of immunotherapy in prostate cancer. The only immunotherapeutic agent used in prostate cancer that I know of that has information related to cancer dormancy is leucine, or also called sagramestin. And this work is largely the result of work by Eric Small. Leucine is a powerful activator of natural killer cells. After 90 days of treatment, cytotoxic T cells appear that are able to recognize and attack prostate cancer cells. This agent is also a powerful activator of antigen-presenting cells, and indeed is used in the preparation of the Provenge vaccine for that reason. Eric has shown in a trial in Journal of Urology that intermittent use of leucine can slow prostate cancer progression in hormone-refractory patients for up to 5 years. He also showed that the combination of ketoconazole with the old hormonal therapy agent ketoconazole had a 75% response rate. So this agent is safe for prolonged administration, indeed for years. So it represents one potential approach to harnessing the immune system for dormancy. So in summary, statins and metformin are cheap and appear to favorably influence prostate cancer, specific survival, and overall survival. Avodart is now generic, well tolerated, but at present there's no evidence that it improves prostate-specific survival or overall survival, but is an agent that should see additional investigation. With leucine, I think what we have is an agent with interesting properties, and that the most I take from this is that immunotherapy might promote cancer dormancy. Again, stepping back and looking at the big picture, our goal in thinking about the treatment of prostate cancer is both to increase the proportion of men entering complete remission and improve the durability of these remissions. Cancer dormancy provides a conceptual framework for improving the durability of remissions, and early results suggest that this can be accomplished while improving both cancer-specific and overall survival. Thank you very much.